where do you normally work, or what is your role, Tim?
Yeah, so I'm currently I'm the respiratory supervisor at Good Sam.
Okay.
So prior to this, I was actually in Jody's position. I was the educator for Chandler.
Gotcha. So we're learning from the experts for sure. So I'll let you take it away, Tim.
All right. How many do we have on the chat? Just kind of estimate wise.
We got 16 right now. We might have like 2 or 3 more log in.
Okay, perfect. Hey everybody, just real quick, just kind of give me an idea of how comfortable you feel currently with mechanical ventilation. Somewhat comfortable, pretty good, not at all. Just so I can kind of get an idea of where everyone is. Now, everyone here is new nurses, right?
Everybody on the call, most of them are new graduates that have about a year to a year and a half to 2 years of on unit experience in medicine.
Okay, so good amount of experience then. Fantastic. I do have the chat box up, so if anyone has questions, feel free to just type questions in at any point. Be happy to answer. Some of this is kind of basic, but I feel like that's where we have to start. But just to kind of get okay, so we got some people who are pretty comfortable with ventilators. That's fine. Hopefully the information that I give you, you find helpful. But again, when we get to the end, if you have some more in-depth questions, please feel free to ask. Okay, so let's go to the first slide here. Pull my laser pointer up. Okay. So first off, we'll just talk real quick about the indications for mechanical ventilation. Obviously, if you've been working in the unit, right? So the first thing is decreased mental status. If you're overly sedated, surgical procedures. If you're a drug overdose, we can't protect your airway, or any other reason why your GCS may be, 8 or less than 8. Those are reasons we're going to intubate you. If you can't protect your airway, we need to support you. The other reason why we're going to typically put you on the ventilator, right, is because of respiratory failure. So ventilation failure is indicated by what? An increased PaCO2. And then you can also have oxygenation failure, which is a decrease in the PO2. So typically less than 50, 60, depending on how sick your patient is. Oftentimes, though, right, these will go together. Usually, if you have a ventilation failure, your oxygenation isn't doing too good. But again, we can be one or the other or both. Real quick, because honestly, I really wasn't sure the level of knowledge and how long you all had been in the unit. So just real quick, let's just touch base again on blood gases. So when we look at blood gases, we have 2 main components in our blood gas. We have our CO2 and our bicarb. Well, the CO2 is the acidic component, and the bicarb is the base component. So these two, basically, it's just a balance. You have a certain amount of acid, you have a certain amount of base, they balance each other out to give us this pH of 7.35 to 7.45. When those balances get out of range, the other may try to compensate, and it can really cause your blood gases to go in a number of directions. So we'll have a little quiz up here real quick. It's pretty simple. Let's look up here at the top. Is this an example of ventilation failure or oxygenation failure?
Don't be shy, y'all.
Yeah, lively group today. Okay, so let's take a look at this. First off, what's our pH? We're acidotic, right? So what's causing our pH to be more acidotic? Well, it's an increase in more acid. So we have a high CO2. Absolutely. Ventilation, you went with it. Okay, I saw the question mark. So kind of sure, maybe not, but again, right? So we have a high CO2. So our CO2 is elevated. That means we're not ventilating enough to blow the CO2 off, which then drives our pH down. So it is actually ventilation failure. Let's go down here to the next one. We have a normal pH. CO2 is still normal, but what do we notice on this one? We have a low PaO2. So of course, in this one, we're leaning towards oxygenation failure. Our patient's not getting enough oxygen into their blood. And then let's look at the third example. What do we think about this third example? In this case, we're acidotic, we have a high CO2, but we also have a low PO2, but kind of less than that 60 threshold. So in this case, we could consider that a combination, right? We have a mixed kind of high CO2, low PO2 that's causing our respiratory failure. And any one of these would be an indicator for mechanical ventilation. Of course, we're looking at other factors as well, but mainly patients with these issues, we're going to ventilate them. So now let's take a look into actual mechanical ventilation. Let's look at the vent screen here. I just put this out as a generic because it doesn't really matter what ventilator you look at. It will look different in a lot of cases, but they all usually have the same information. So this is specifically the Servo I. We also have a Servo U, and if you're ever come over to Good Sam, we have Hamilton G5s. So they all look a little different, but they all will have the same information. So there's always going to be some place where the ventilator mode is going to be located. There's always going to be an area where we're going to have set actual settings that we're dialing in to give to our patient. And then there's always going to be a section where we see live data. What is our patient actually doing? So this is what we want them to do. This is what they're doing. When we look at waveforms, notice it's actually color coordinated. And this is a nice feature with the Servo. Your pressure waveform coordinates to which is yellow, coordinates to the yellow parameters on the ventilator screen. So your pressure waves in yellow, all of your pressure parameters are in yellow. Your flow waveform is in green. All of the waveforms that measure oxygen and respiratory rate are in green. And then all of your volumes are in blue, which coordinate to a blue waveform. So it's really easy to kind of pinpoint. These waveforms are just visual representations of these numbers here. From a respiratory standpoint, these are really important for us because this helps us see a lot more than just reading numbers. From a nursing standpoint, more so, you're going to be more, I would say for you all to be more worried about the safety aspects of mechanical ventilation, to be extra set of eyes. And we'll get into that later on. One thing I want to get into real quick is just these breath types. Some of these words you've probably heard before, may not completely understand exactly what they are. But when we say a controlled or a mandatory breath, this is a breath that is started by the ventilator and is ended by the ventilator. The patient has absolutely no control over this. It is all ventilator driven. If I give you an assisted breath on the ventilator, the breath is started by the patient. So the patient makes effort. The patient, after they make that effort, the ventilator says, oh, my patient's working. I sense that they're making effort to breathe. Then it takes over and the vent delivers the breath and continues the breath through the duration of the settings. After the patient starts this breath, the patient has no other control. It diverts back to the ventilator. Then you have spontaneous breaths. So these are breaths that start and stop all from patient effort. The patient is generally in full control. We do have some minute settings we can adjust for a little bit more comfort, even in spontaneous breathing. But most modes, whether I'm talking about volume control, PRVC, pressure control, they all use a combination of breath types. You usually, unless you're in just pressure support where everything's spontaneous, most modes give you a combination of controlled and assisted, depending on who starts the breath. Any questions about that? Please feel free to interact. Zoom is the worst when it comes to these classes because I can't tell how many people are sleeping. We'll keep going. Okay. Yeah. Okay. So we were talking about blood gases a minute ago, and we want to determine how do we fix that high CO2, or how do we control our patient's ventilation? What are the two factors? What are the two parameters that we can adjust on the ventilator that can help ventilate our patient more? And so I have them up here on the screen. Obviously, I'll start here at the bottom. The first one is respiratory rate. Right. Absolutely. The more breaths I give per minute, the more my patient can help blow off CO2. Usually, we're going to set somewhere around a 10 to 20 breath a minute range. When I was a newer RT, this was actually lower. It was like 8 to 12, 8 to 15. But that's because back then we gave much bigger tidal volumes. For lung safety, as you've probably heard, we like ARDSNet, we like lung protection strategies. We have slowly lowered our tidal volumes over the last 10, 15, 20 years. So in order to still kind of compensate, we've started to turn our rates up. Now, looking at our tidal volume, we can set the volume directly, that size of the breath that we're delivering to the lung. Usually we're targeting or we're setting a volume somewhere between 6 to 8 mLs per kilogram of ideal body weight. Now, why is ideal body weight important? What's ideal body weight based off of? In general, we're basing ideal body weight off of our patient's height, right? So someone who is, if you had two patients, height, weight, BMI. So we actually don't use BMI for mechanical ventilation, because if you're 6 foot tall, it doesn't matter if you're 300 pounds or 120 pounds. Your lungs are actually the same size, because the length and overall size of your lungs is determined by your height. So I'm not going to give you more volume simply because you're heavier. I'm going to give you more or less volume based on your height. And so we target 6 to 8 mLs per kilogram of ideal body weight. If you've been in the pulmonary unit, I'm not sure how much they do it as much anymore, but several years ago when we had a physician here named Dr. Morris, we actually had to grab tape measures and measure the height of our patient. He wanted a very accurate height. And so it is, from a lung protection strategy, to have tidal volumes that we determine are safe for our patients, we're aiming for the 6 to 8 mLs per kilogram of ideal body weight. Now, also, and we're going to talk about this here in a second, but we don't always have to set volume to blow off CO2. We can set a pressure, and depending on that pressure can help determine our tidal volume. And we can titrate that pressure up and down to try to target this 6 to 8 mLs of ideal body weight. When you multiply your tidal volume times your respiratory rate, you end up with something called minute ventilation. So how much air is our patient moving in and out per minute? And this is really where the magic happens, right? I could have a low volume, but a high rate, and pretty much achieve the same thing as if I had a high volume and a low rate. My minute volume's the same. So in reality, most of the time, my CO2 is going to be the same. How we target that is really based on our patient and specifically what their individual issues are. Any questions about CO2 and controlling ventilation? So on the other side, how do we fix that low PO2? How do we control the oxygenation and improve our patient's oxygenation? So the first thing we can do is, of course, we can increase the oxygen. And we can set the oxygen on the ventilator anywhere from 21 to 100%. So where do we typically find oxygen is dangerous is generally above 60%. So a general rule of thumb is I'll typically take my oxygen up to 60. Then if I'm still having a problem oxygenating, then I'll start to turn my PEEP up. What is the one parameter that you should be monitoring, especially from a nurse standpoint? What should you be monitoring if your patient is on a lot of PEEP or high levels of PEEP? What's that one vital sign that you should probably keep an eye on pretty closely?
Think about what
All right.
pressure in the lungs can do.
Yeah, blood pressure, absolutely. So BP. And why is that? Remember, as we increase the PEEP, we're turning up the pressure in the lung. I have a video I'm going to show you here in a second, but we turn that pressure up, and what it can actually do is decrease venous return, which decreases cardiac output, and then ultimately can lower your blood pressure. Typically for a slightly healthier patient, you're not running many pressors, the patient's not very sick, 5 of PEEP is substantial and it's good enough, and you're not going to usually have blood pressure issues based on that. You start getting into your patients who have ARDS and they're on multiple pressors to maintain blood pressure, and maybe they're really hypovolemic as well. And so you can really affect your blood pressure by turning up the PEEP. Now, I just had a patient 3 days ago on a PEEP of 24. So it's not uncommon to have high levels of PEEP on patients, especially if they're really sick. So, but PEEP itself, and this is where I find a lot of people don't really understand what PEEP actually is. Yes, it's this minimum pressure we're always putting on the lung. So if we went back and looked at our ventilator screen, notice here I have a PEEP of 5. This 5 is represented by this line right here. So this dotted white line being 0, you can see we never let our lung fully collapse, do we? The PEEP stops 5 above. So it doesn't matter what your patient does, the pressure never goes lower than where your PEEP is. And that's important because what that does is it keeps the lungs from deflating. It keeps our lungs from losing recruitment. So I have a video. There's not really any audio to this, but I'm just going to kind of, let's see if I can get this to play here. Turn my laser. Okay. In this video, we have a set of lungs here. And you'll notice that the EMT, he's actually bagging the lungs, but he has no PEEP on the lung. Do you see, first off, notice how fast he's breathing and how quickly he's squeezing that bag. In reality, in the real world, we would never bag a patient that fast, right? He's just doing that to kind of prove an example. Notice, as soon as he lets off the ambu bag, what happens? The lungs almost deflate, right? There's nothing there causing that end expiratory resistance, that end expiratory pressure. There's nothing there allowing the air to stay in the lungs and hold the lungs open. So now he's going to disconnect and he's going to connect to a ambu bag that has a PEEP valve. And so the PEEP on this PEEP valve versus PEEP on the ventilator is the exact same thing. There's no difference. You'll notice a big difference. Right now, he's on a PEEP of 5, and he doesn't have to nearly bag as hard or as vigorously, does he? He's able to keep some lung recruitment. Now watch what happens when he turns the PEEP up even higher. He is still bagging faster, but it's just to essentially demonstrate the effects of PEEP. So we get a lot more lung recruitment with just that little bit of resistance to exhalation. And that's really what we're trying to do. So the more PEEP we put on a patient, the harder it is for that air to get out of their lungs. So we kind of trap the air and it forces the lungs to stay open and recruit. Again, we have to balance this though with protecting our patient as far as not over distending their lungs or bottoming out their blood pressure. Any questions, guys? Was that helpful about understanding PEEP and kind of what it's actually doing to the lung? All right. So now we're going to kind of really get into the kind of the essence of mechanical ventilation. So the first 2 parameters you always kind of hear about with mechanical ventilation is volume and pressure, the volume we deliver to the patients and the pressure we deliver to the lung. What I want to point out is that pressure and volume are directly related to each other. And this is kind of why I have a picture of a car tire, because to me, this is a good example that most people can understand. The more air I add into my tire, what does the pressure do? It goes up. Well, it's the same thing with our lungs. The more volume of air I put into our lungs, the more pressure goes into our lungs. The more volume of air I let out of our lungs, the less pressure goes in. And it's the same thing with the tire, right? The more air we put into a small space, the more pressure builds. So because they're related to each other, you can only control volume or pressure at one time. If I control my volume, my pressure varies. If I control my pressure, my volume varies, but they always vary in the same direction. If I give more pressure, I give more volume. If I give less pressure, I give less volume, vice versa. But again, we can never control both at the same time. That's why we have a mode called pressure control, because we're controlling the pressure. Or I have a mode called volume control because we're controlling the volume. The other variable, the other parameter varies. and we have no control over that. It is simply related to our patient's compliance of the lungs, the resistance, and their overall health. Two patients the exact same size, the exact same volume, can have drastically different pressures depending on what's wrong with the lung. So let's take a look at the first basic mode. The first basic mode we're looking at is volume control. I'll bring my pointer back up. So again, in volume control, what are we doing? We are setting a volume, and that's the volume we determined based on, again, that ideal body weight and their height. We've determined that this is the volume our patient needs. So you see here, we're in volume control. We're delivering a volume of 500. But because of that, my pressure again will vary. So this peak pressure here can be whatever it is, again, based on our patient's lung compliance, resistance, and what's wrong with them, their general overall health. They could be the same height, so you give the same volume, but one could be substantially more overweight than the other. The pressures will always be different because it's all based on those factors. But generally what this is saying for this particular patient, to give 500 tidal volume into my patient's lungs, 31 centimeters of water pressure is what it takes to deliver that volume. So if our patient had a sudden change in compliance, or they coughed or anything, right, you see this peak pressure change. What I want to get stressed to you about volume control, because honestly, how often, if you all had to guess, how often would you say you've seen a patient on just volume control? If you haven't, don't worry, because it's pretty rare. You're exactly right. It's less common, not a lot. And there's a reason, because I have to control the volume. The patient, we have dialed in that this patient, no matter what happens, no matter how hard they work, no matter what they do, the patient will only get a tidal volume of 500. Well, you can imagine that's pretty limiting. That's pretty limiting, isn't it? And especially when you consider that the tidal volumes we give to patients nowadays are very, very small to be lung protective. When I first graduated respiratory school, we were setting 10 to 15 mLs per kg tidal volumes. It was not uncommon for a patient 6 foot, 6'2" to have a tidal volume of 11 or 1200 mLs. But now we're only giving 400 or 500. And so when that patient wakes, especially when that patient's awake, do you think the 500's enough to meet their demand? So because volume control has such a strict regimen, these strict settings, everything we deliver to the patient is set and constant, and the limited flow can cause air hunger. So it's not uncommon for patients, especially if they're awake, to just be really desynchronous and just not be comfortable at all. And if they're in volume control, it shows really quickly. And then what we end up doing, instead of changing their mode or giving them more volume or trying to wean them, we end up sedating them a lot. And so volume control just doesn't get used a lot anymore, simply because it's just not comfortable. And if you ever get the chance to breathe, like we used to take before COVID, we used to take filtered mouthpieces and put them on the vent circuits and have nurses in one of the pulmonary classes breathe on volume control. And it's horribly uncomfortable. Most of them couldn't even keep their lips around the mouthpiece. So this is why we kind of stay away from it for most patients, especially if they're not sedated. And then of course the basic settings, we're setting the peak, the FiO2, the respiratory rate, and the tidal volume. Any comments or questions about volume control? If you do, feel free to put them in the chat. We'll come back to it. Absolutely. So now we flip to the other side, right? We're not controlling volume anymore. We're controlling pressure. So now I have a set pressure delivered each breath. I'm not controlling my volume anymore. My volume will vary, again, based on those exact same parameters: patient effort, lung compliance, resistance, and just the overall health of our patient. Oh, that's a really good question. Let me come back. Actually, if anyone can see the question, what's the difference between volume control and assist control? So all assist control means is what type of breaths we're getting. So we come back to this slide here, these breath types. If you're an assist control, you're getting a combination of assisted and controlled breaths. However, on the ventilator, I can have assist control pressure control, assist control volume control, assist control PRVC. Now on the servos, assist control is not written anywhere. If it's not written, it's basically the manual says if assist control isn't there, you just assume it is assist control. So volume control and assist control are two different things. This assist control just tells you what kind of breaths you're going to get. It doesn't say if you're controlling volume. They're two completely different things, but that's actually a very, very common misunderstanding that I find a lot with people learning mechanical ventilation. Brian, did that answer your question? Awesome. So let's go back to pressure control. Again, so we're setting pressures. So if we look at our pressure here, notice I still have my PEEP of 5. Again, that's that minimum pressure I'm delivering to the lung. You can see here on our waveform. But now instead of a volume over here in this lower corner, I have pressure control above PEEP. So every time a breath is given, I have a PEEP of 5, and then the breath starts, and then I add 15 of pressure above it. And so I get up here to my top pressure, and that gives me a pressure of 20, 21. So it's not exactly 20, but it's very close. And usually the ventilator is going to hit it right on the number, but it's just the addition of these two. It's this pressure added to the PEEP, and that's the high pressure, the peak pressure that the patient's going to get every breath. And the volume that they get, again, is varied completely on their effort and their compliance and resistance. The nice thing about pressure control is because we're not trying to strictly control a tidal volume, it can kind of be whatever it wants. The patient can get variable flow. That may not mean much to you, but what it really means is it's really comfortable. Breathing on pressure control versus volume control is a night and day difference. And so for a lot of patients, pressure control is preferable and it's really comfortable. The only difference between the settings on that and volume control is, again, we're just setting a pressure. And so, again, if we're looking at volume and pressure control, let's start with pressure control and then we'll go back to volume control here in just a second. Say I have my patient who's breathing here. Now we're controlling pressure, so it doesn't matter what happens, this pressure is not going to change, but the volumes could. What if my patient developed a pneumothorax in this mode right now? What would we expect to see happen? What would we expect to change? Any ideas? So remember, we're in pressure control, right? It doesn't matter what happens to our patients, our peak pressures will never change. The only thing that will change will be that variable, which is our tidal volume. Right, Sarah, you got it. You got it. So if I had a pneumo, the pressures won't change. What you'll see is the tidal volumes will drop very, very low. If we had the same thing happen to our patient in volume control, so no difference other than the mode, if our patient still develops a pneumothorax, now what do we expect to change? Well, we know our volume's not going to change because we're in volume control. So what's that pressure going to do? It's going to go way up. And usually, right, you're in a volume control type mode, usually not volume control, but maybe PRVC. Yeah, you're seeing those pressures go way up. And so what's the most common alarm you all think you encounter on a daily basis? The pressure alarm, isn't it? Patient coughs, secretions, anything that gets in the way of the breath getting to the patient is going to cause that pressure to increase. And so, you know, how many times have you walked into a room, the ventilator alarms, by the time you get in there, it's completely gone, right? Because that patient was coughing and then they stopped and it went away completely. And so depending on what mode you're in, it's very important to understand what can be the changes. And the reason I say that is because if you have a patient in volume control and you're at a setting of 500, and first rounds you come in and you notice that the patient has a peak pressure of 30. Not great, but it's not horrible. But then 4 hours later, you come in and you notice it's like 37. Hopefully it's hitting an alarm, but maybe the RT didn't set the alarm appropriately. So, and now you come in 4 hours later and the peak pressure is 50 or 44, right? You're seeing this trend over time that our peak pressures are getting higher for the same volume. Well, that could mean that our patient's getting worse, right? Our patient could really be getting worse. And so keeping an eye on your pressures throughout the day can be somewhat of an indication that there's a change in your patient's lungs. If I'm in pressure control, going through that exact same scenario, my pressure wouldn't change. But 8 o'clock in the morning, they were getting 400 tidal volumes. Now it's noon and they're getting 340. And then you come back again, 2 hours later, and they're getting 285. That volume has slowly decreased over the shift, even though we're giving them the same pressures. So again, we're seeing a trend in our patient's compliance or just some type of lung issue developing that would cause these variables to change. And so while the RT is looking at this too, I always suggest, especially if you're dealing with patients in pressure control, keep an eye on your patient's volumes and minute ventilation. Because if your patient has a change in their lung compliance or resistance, these numbers will drop pretty drastically. And unfortunately, we found a lot of these alarms at like 3 liters a minute, which is not good. So we get on our RTs a lot about having those alarms set appropriately, but sometimes they're not. So we do rely sometimes for nursing to catch these volumes dropping. I know I kind of rambled. Any questions about the first 2 modes we just talked about? All right. So now let's talk about, and this is the big one here, right? This is probably the mode you all see the majority of the time, right? PRVC. So pressure regulated volume control. You would assume from the name pressure regulated volume control that it is a form of volume control, when in actuality it is an advanced controlled form of pressure control. So we have a targeted volume. So we have a tidal volume that is set, but it's not always going to be exactly that volume. It's a target. We're telling the ventilator we want to target this volume, but the ventilator will actually adjust the pressure up and down every breath to hit that volume. So it allows the ventilator to maintain volumes when patients' conditions change. We think back to that patient who just, had a pneumothorax, right? Well, they were getting a certain volume at a certain pressure. All of a sudden that volume dropped. So what did the ventilator do to compensate? It turned the pressure up a little bit to give the patient more volume, but it does it slower. So as your patient's compliance and resistance changes, the ventilator will adjust the pressure automatically to maintain that target volume. Within reason, there are alarms and there are other safety nets to keep the patient from getting injured. But it's actually a pretty different mode, even though you think of it as maybe being volume control. It's a very adaptive mode, and it saves us a lot of work sometimes from having to adjust the ventilator constantly to target a certain volume. The ventilator just does it automatically. However, there is a very common form of asynchrony with patients who are awake and hungry, air hungry, just because of the nature of the mode. We're not going to get into that too much today, but if anytime you have an RT, if you've ever heard the word PRVC vortex or PRVC desynchrony, it is a very specific kind of desynchrony that's related to just this mode. Show you a picture of PRVC here. Notice we're not in volume control, but we do have a set volume. And here's our pressure. If for some reason the next breath came back and the exhaled volume was 300, The very next breath, the ventilator would turn up the pressure to try to get back to 450. And if the breath after that, it was 600, the ventilator would turn the pressure down to get back to 450. So it makes an adjustment every breath to try to stay around this tidal volume. As your patient's effort and compliance and resistance change. What I like to point out though in this slide is, so some people don't believe me when I say pressure control and PRVC are essentially the same mode. Other than the algorithm on it changing up and down, it works virtually the same way. So from an RT standpoint, when I'm diagnosing a patient who maybe is asynchronous in pressure support versus asynchronous in PRVC, I'm going to treat them identically because it's really, in a lot of ways, the same mode. Notice here I have a picture of PRVC. Here's a picture of pressure control. If I were to cover up the titles and you just looked at these patterns of these waveforms, they look almost identical, don't they? Again, it's because they're essentially the same mode, but PRVC has that algorithm that will help change the pressure. Thank you. Yeah, PRVC is so misunderstood from even, to be honest, from even an RT perspective. So I try to get these concepts out because there's something you're gonna see real quick, just as to throw that out there. PRVC to synchrony, again, is a very common thing. I can walk on any unit in the hospital and find someone in this. What I want you to watch out for is if you have an awake patient on PRVC and they're kind of thrashing all over the bed, if their peak pressures are low, now this isn't PRVC, but if we went back, if their peak pressures are really low and their volumes are still bigger than their tidal volume, your patient's making a lot of effort and they're not getting what they want. But as your patient makes effort and keeps pulling volumes that are bigger, the ventilator will keep taking pressure away and support away. And so the patient ends up doing all the work. And what do we end up doing to them half the time? Sedating them or knocking them out, when really they probably just need to be changed to a different mode. Ask any of your RTs about PRVC to synchrony, and in your unit, I guarantee you they can find you an example of it. Next time I do a lecture like this, I'll put an example in it to you, I promise. So the last mode we're going to talk about today is pressure support. So now we go from the control modes where we're taking care of probably sicker patients, patients who aren't ready to wean, and now we're going to more pressure support. So what's the nice thing about pressure support? It's really comfortable. It's really there to help our patients wean from the ventilator. And what parameters missing? What's missing here? Respiratory rate. We're not telling the patient how fast they can breathe. We're not telling them how big of a breath they can take. It's all controlled by the patient's effort. But we're still setting a pressure. So you see, we still have a pressure of 8 over a pressure of 5. Added together, it's around 13 or 14. Not a big deal, completely fine. Pressure support was developed as a way to help wean your patients without actually taking them off the ventilator. Years ago, when we weren't using pressure support a lot, we did something called T-piece trials. So imagine an aerosol bottle like you would see for a trach collar hooked up to a T-piece, and we would hook that T-piece straight to the ET tube, and we would just let the patient breathe through their ET tube on just some aerosol for an hour. And we would come back and we'd measure their mechanics, their vital capacity, and we'd get a blood gas, and if it all looked good, we'd extubate. Well, how hard do you think it was for that patient to sit there for an hour and breathe through essentially a long straw? It's really difficult. There's a lot of extra resistance created by the ET tube. So really the pressure support is there to overcome that resistance, to make it as if the patient's not breathing through the tube at all. And this is what they would do if they didn't have the tube in. So it's a way to neutralize the ET tube to make it a little bit easier for the patient to breathe during the breathing trial. Some other nice things about pressure support, it does have backup mode. You know, if the patient stops breathing or goes apneic. Yeah, and you're right. So pressure support trials are much better predictors because, again, a lot of times when we're using trach collar trials, like we were wearing the patients out prematurely just by having them breathe through the straw. So Yes, we much prefer, but we still have physicians every once in a while that ask for a T-piece trial. It's very rare anymore, but it does happen. So good. Okay, that's a good question. So volume support, the reason why we prefer pressure support over volume support is volume support is like PRVC. It's pressure support, but you have a targeted volume. Well, if I'm targeting the volume and the pressures can change in volume support a lot, that's why I don't even talk about it in the slides, is because we don't use it a whole lot. Volume support will adjust the pressure up and down. So this pressure will get adjusted up and down in volume support to target a set volume. So you'll have 450 or 400. So we really don't get an indication of how well our patient's doing if they're on volume support. So we have no idea what they would do if we took them off the ventilator, because the ventilator is actually supporting them more than you think they are. Nicholas, did that answer your question? So volume support is so when I worked at an LTAC, a vent weaning facility, volume support was used a lot, not necessarily as a weaning tool, but say we would do someone on pressure support for a couple hours, but they tucker out and get tired. Instead of flipping them back to a complete control mode, we'd put them on volume support to kind of help them rest, but still at the same time keep them working. And so kind of it's an intermediate, it's a go-between. You're never hardly going to see anyone get extubated off of volume support, because again, you're not going to know what the patient's actually doing versus what the vent's helping them do. So we do again use pressure support to wean our patients, but also another useful situation where pressure support can come in handy is if you have a patient with some type of brain injury, if they're Kussmaul breathing, Cheyne-Stokes, patients who have rapid rate, respiratory rates, or they have shallow breathing, then bigger breathing. If you have them in a control mode, they're going to alarm on you all day, right? They're just going to alarm and be desynchronous and drive you and the RT crazy all day. So if we're not really using it as a weaning tool in that sense, so I may have a higher level of pressure support set, but really I'm just putting my neurological patient on pressure support as a way to keep them synchronous and to keep them and to actually help them ventilate a little bit better than if they were in a control mode, if that makes sense. Really, we're just trying to match the ventilator to what the patient wants to do versus say what we want them to do. Yeah, so SIMV is similar to what we talked about earlier, which is called assist control. SIMV is just another type of breathing pattern. In SIMV, you can actually get controlled breaths, assisted breaths, and spontaneous breaths all at once. So in SIMV, I can set their rate really low, and we expect the patient to breathe much faster and kind of pull spontaneous breaths in between, say, a rate of 6, 8, or 10. So we don't use SIMV a whole lot because SIMV has also been proven to keep a patient on the ventilator for up to 2 days longer. We used to wean from it quite a bit as well, but SIMV is really fallen out of favor because it's not that helpful. It's more of a hindrance. So again, you can have a patient, and if you ever venture in, if you ever see a servo that's just sitting there not being used, or ask your RT, when you look at the menu, you will see where it will say SIMV pressure control, SIMV volume control, SIMV PRVC. Then you just have the regular ones: volume control, pressure control, PRVC. So it has SIMV next to it, then that just means you're going to get a combination of all 3 different types of breaths. And if it's volume control, and if it doesn't have SIMV next to it, you just assume it's assist control. So again, SIMV is just something we don't use a lot, just simply because it doesn't, for most of our patients, it does not provide any benefit. We're just going to put you in regular assist control, volume control, or assist control, PRVC, or pressure control, and we can pretty much do what we need to do for most of our patients. But yes, so in SIMV, Back in the day, we would turn your respiratory rate way down to like 4. And then the patient would just do all the breathing, the rest of the breathing themselves. And we could use that almost as pressure support. We're only giving them 4 breaths a minute. Everything else they're doing by themselves. So if they maintain a good minute ventilation, good tidal volume, and their CO2 stays okay, then we could extubate them from SIMV just the same. But again, our management of it is poor, and it causes the patients to stay on the ventilator a lot longer. So we just, if you can over breathe the ventilator at all, we're just going to put you in pressure support and let you breathe. Emma, I'm sorry again if I rambled, but hope did that make sense? Was that helpful? Awesome. So notice in pressure support that our patient is in full control. Look at this. They have a big giant tidal volume and then a small tidal volume. They have big giant breaths, small breaths. And the patient can get any combination of that they want in pressure support. So as you can imagine, this is the most comfortable mode. This is the mode that really helps your patient stay awake and alert without trying to thrash and jump out of the bed. And it really a lot of times will keep them from being sedated. Again, of course, this is one part, our patient breathes really well, but also we have to pay attention to the amount of support we're giving them. So when we talked about volume support a second ago from that other question, right? You could have a patient getting a pressure support of like 20 centimeters of water over 5. Well, that's doing a lot of work for a patient. So when we go to wean and extubate our patients, we're usually going to see a pressure support somewhere between 5 to 10. When I first started, we could wean and extubate a lot of people off of pressure supports of 10. Now, usually what we're seeing is pressure supports of 8, pressure support of 5 over 5. We're giving very, very little pressure, and we want the patient to do work, and so they can show us what they're capable of doing. I've even had a few patients on pressure supports of 0. So it's not uncommon to see these pressures really low, especially if you're trying to figure out, are we weaning them or not? Are we extubating them soon or not? Any questions about pressure support? Real quick, we'll touch on alarms. So again, what are reasons my peak airway pressure would go high? Well, here's some common situations. Secretions. How many times have you heard the vent alarm? You go in there and suction them, it calms right down. Biting the ET tube, a narrow ET tube, or anything that would make the ET tube smaller, say secretions build up inside of it and it gets plugged off. Any of those things could affect your peak airway pressure and make it go higher, because it's just resistance. It's something getting in the way of the air moving into the patient, and so it makes the pressures go really high. Again, coughing. Your patient coughs. By the time you get in the room, the alarm stopped alarming and the patient looks back to normal. Usually, though, with these 3, it happens quickly. It can be fixed quickly, right? I can put a bite block in. I can suction or maybe lavage. I can put up, again, I can maybe if your patient, once your patient gets suctioned out, they stop coughing. Those things happen quick. The pressure jumps up, but we can get the pressures down pretty quickly. However, if our patient's getting a worsening lung compliance, this takes me back to earlier when I said, if you see this pressure slowly trending up over time, then maybe your patient's getting worse over time. One of the most common causes of worsening lung compliance is sepsis, right? ARDS, a lot of our ARDS is caused by our septic patients. So as we have a patient who's, they're spiking a temp, their white blood count cell, they're getting really high, and that patient's just septic and getting worse. You could see, especially if they've been on a ventilator for any moderate length of time, you could start to see that lung compliance getting worse and these peak pressures starting to climb. We can't fix that quickly, can we? Those are when we have to start doing, possibly proning or really dive deep into lung protection strategies, and it takes a long time to get those patients better. So on the other side of things, what if we see a low volume? We have a minute ventilation alarm that's low. Well, the first thing we always going to look for is leaks. Do we have a leak somewhere, around the cuff, around one of the connection sites? Are we losing a little bit of air? That's going to be your most likely cause for a lot of your leaks as to why you're not getting the volumes back. or you're getting low volume alarms. Pretty much the only reason. And then again, if you're in pressure control, and again, your lung compliance is getting worse, your patient's getting worse, you're going to slowly start to see those tidal volumes and that minute ventilation drop. And so if you're in pressure control, the parameter I want you to pay attention to is your volumes. If you're in PRVC or volume control, you need to pay attention to your peak pressures. So it's really going to be, it's really knowing what mode you're in from a nursing standpoint, knowing what mode you're in and knowing what parameters are variable, so you can keep an eye on your patient from your aspect and see, oh, is my patient possibly getting worse? Or maybe they're even improving. So that's just a good thing to keep your eye on. Real quick, this kind of fun little, it's really nothing crazy, but it's a little thing I like to do at the end, just to kind of show you that there are a lot more modes than what we talked about today. So for instance, there's bi-vent, bi-level, APRV, and TCAV. Here's the crazy part, and here's why it's sometimes difficult to be a respiratory therapist. All of this is the same mode. They're all the same. Every one of these belongs to a different manufacturer of ventilator. So the terminology among ventilator companies, they change them on every ventilator. So bi-vent is servo, bi-level is the Puritan Bennett 840, APRV is the Hamilton, TCAV is the Draeger. But they all do the same thing. So some of our RTs, myself included, we bounce around to different hospitals and we encounter different terminology all the time. And it's the same thing with this one. PRVC, volume control plus, APV, VG, autoflow, the list goes on and on. They're all the same modes. Every one of them is the same. They do the exact same thing. They may function slightly differently from an engineering standpoint, but for us, they work identical. So knowing what ventilator we have and knowing these modes, it can make it quite confusing sometimes. And then I go down here to this last list: auto mode, ASV, NAVA, PAV, PAV Plus. These are proprietary modes that only one ventilator has. So auto mode belongs to servo, NAVA belongs to servo, ASV belongs to a Hamilton, PAV and PAV Plus belong to Puritan Bennett. I know these names don't mean anything to you all probably, but every ventilator has some special mode that no one else has, and they all work very differently. So you have the common modes that all have the same name. You have all these modes that have different names with different algorithms. So it's a lot to keep up with. Again, the majority of stuff we use, the most common mode used across the world is still volume control, because it seems to be the easiest for everyone to understand. But if I had to ask you, so kind of as a way to kind of end everything, how many ventilator modes do you think are FDA approved in the United States? If you had to guess. Three. I just listed 9. 100 plus, that's a good guess. Yeah, I like that one. All right. Elise, I think you were missing 2 zeros. So there's actually 300 FDA approved vent modes. Now this goes back to the creation of the first ventilator. Obviously there's some modes we don't use anymore that really don't exist on today's equipment, but a lot of modes do the same thing. They just have different names based on the manufacturer. And there are probably 30 different vent manufacturers across the world. So lots and lots of vent modes. Understanding even some of them is a challenge. And so again, hopefully right, exactly. Brian, it's interesting to bring that up because there is no research that points to any one ventilator mode being better than any other mode. It's actually more important that you use the mode that you're most confident in managing and you know about, right? So, I complain all the time about, physicians not using a more appropriate mode, but honestly, if that's the only mode they're familiar with and they can manage it well, then it's still better than putting someone in a mode and completely messing it up and causing more harm. So I completely agree. Yes, the devices mode devices, but it's funny because a lot of the vent manufacturers I talk to, they wait years for the modes to get approved. If they come up with something new, when they're just repurposing something from the future, from the past, it usually doesn't take as long. Last slide really is just some food for thought. Anytime that changes are made, please contact your RT. For most situations, let the physicians or the RTs make the changes. Don't take that liability. Know where your O2 breath button is. If you're suctioning your patient, hit the O2 breath button. It gives them a boost of oxygen for the suctioning, and it also silences your alarm at the same time. Depending on the RT you talk to, and depending on the game plan, you know, I don't mind personally. I don't mind if nurses make small changes, especially in oxygen. Again, whatever your department and your floor's rules are, but as long as you're communicating that with the RT, I don't have an issue with it. If your ventilator's alarming, check your patient. Don't let it just sit there and alarm. How many times I've walked into a room that's just disconnected and no one got up to go in, and then call your RT. And bag your patient. Again, if your ventilator's alarming and you have no idea why and it won't go away, call your RT and start bagging your patient. I would rather you do that than leave them on the ventilator to suffer. And never hit the silence button or change those alarm settings. It's alarming for a reason. We just need to get in there and figure out why. That's all I have, guys. If there are any questions, feel free to ask. I think we hit right at an hour too, so it's good timing.